well, welcome everyone. Looks like we'll get started. My name is Andrew Dang, and I'd like to personally thank you all for taking the time to tune into our AOCPMR Resident Panel tonight. So hopefully by the end of tonight's panel, you'll be able to learn a little bit more about PMR as a profession, hopefully solidify the reasons why PMR is an absolutely incredible field to go into, and to hopefully answer all your questions when it comes to applying for PMR. So this panel would not be possible without the amazing work of the AOCPMR Student Council, which you guys can see on the screen here. Here's some of the people that helped make this panel happen. So thank you all so much for your help. Before we begin, I wanted to introduce you guys to AOCPMR. For those of you who aren't aware of us, we are the National Osteopathic Physical Medicine and Rehab Organization. AOCPMR is a family, and I think what makes AOCPMR so special is the amount of mentorship that goes on within our organization and all the leadership opportunities that are available for medical students and residents. So whether you're a first-year medical student or you are a fourth-year medical student, if you're interested in getting involved in AOCPMR, whether it's through our mentorship program, whether it's just becoming a member or whether it's getting involved with our student council, feel free to send me an email. Let me kind of move this out of the way so you can see. Let's see, there we go. There's my email at the bottom right of the screen. So yeah, feel free to send me an email. We'd love to have you. All right, so introducing our wonderful panelists today, we have 5 DO residents. Kirstin, do you want to start us off and we can kind of go down the line? Just introduce yourself, where you're going to residency, and maybe what area of PMR you're interested in.
Yeah, sure thing. Nice to meet everybody. I'm Kirstin. Can you hear me okay? Awesome. So I am over at Carolina's Rehab in Charlotte, did med school up in Michigan at Michigan State. Still debating exactly what I want to focus on, but interested in kind of general MSK, general physiatry, NP care, and some integrative medicine too.
That was perfect. Dr. Smith,
Right.
do you want to introduce yourself?
Sure. Hi, everyone. My name is Michael Smith. I am a current PGY3 at the University of Pittsburgh Medical Center here in Pittsburgh, Pennsylvania. Originally from Florida, I did medical school at Nova Southeastern University. My clinical entrance, at this point, I'm pursuing a fellowship in interventional spine, but there's a few other things that I'm interested in: spasticity management. I've actually had really good experiences with my inpatient rehab experiences in Pittsburgh. And I'm also an avid lover and user of osteopathic manipulative medicine. So thanks for having us.
Awesome. Thank you, Dr. Smith. Dr. Parrott, do you want to introduce yourself?
Hey, I'm Mike Parrott. I'm a PGY3 here at University of Kentucky. I did my medical school down in Lincoln Memorial in Tennessee. Did undergrad at UK from about an hour north of here, like Cincinnati, Northern Kentucky border. Clinical interest, predominantly sports and spine, love MSK ultrasound, interventional kind of pain, and then some sports medicine as well.
Perfect. Dr. Clark, do you want to introduce yourself?
Hi, everyone. My name's Stephanie. I'm from Seattle originally. I did medical school at Western University of Health Sciences in California, and I'm a current 3rd year at Mayo Clinic. My clinical interests lie in sports medicine, musculoskeletal ultrasound, and regenerative medicine.
Awesome. Thank you. And Dad, you want to run us out? Dr. Wing?
Yes, I keep checking up on my new puppy. I got a new Boston Terrier, so just making sure it's sleeping.
Oh.
I'm Dat. I did medical school at Philadelphia College of Osteopathic Medicine. I also did an extra year as an OMM fellow. which has helped me significantly. I did residency at Baylor College of Medicine, and I am now an interventional pain fellow at an ACGME accredited program down in Texas, UTMB. You guys can ask me about fellowship stuff, because I applied to sports and spine and the pain match, so I'm pretty familiar with all three of those. So ask me anything about that.
Perfect. Thank you, Dr. Nguyen. All right, so we'll move on to our panel questions now. I'll turn it over to soon Dr. Grant and Edward. We'll go through our user submitted questions first in a sort of like a rapid fire style, and then if we have time to address the chat questions, we'll definitely try to get to them. If you have any questions today that you think of, yeah, please go ahead and use the chat and we'll try to get to them. I'll pass it over to you guys.
Well, good evening, everyone. My name is Edward Pingenot, and I will be co-moderating the first portion of our panel this evening. Then we'll hand it over to Grant Albritton, who is our vice president. But want to go ahead and get started. Thanks everyone again for participating. First question in our first series of questions are really going to be centered around the osteopathic journey to physical medicine and rehabilitation. And really anyone can feel free to speak up. We might speak over one another a little bit, but just feel free to answer if something comes to mind. So first question, what are some of the ways that you can use your DO degree in residency, whether it be a holistic approach, OMM, and OMT? How are you using OMM in your PM&R program?
Well, it's kind of weird in these times with COVID and everyone not wanting to touch. But pre-COVID, OMT and my palpation skills that we learned in DO school definitely significantly, made a lot of the patients trust me a lot more than a lot of my other colleagues.
And I'll follow up and say that just that hands-on experience, you get so much more from a patient when you can actually feel comfortable putting your hands on them and examining them. Even today, had our didactics and we were doing the ultrasound of the hip, and we have both some osteopathic and allopathic residents, and just kind of being comfortable with the anatomy and knowing that it's part of your learning. You palpate the ASIS and not really think twice about it. You just have a really nice integration of the anatomy and then how that can translate clinically once you actually get to use it on patients.
I'll answer this also. So I know this AOCPMR is putting on this this talk, and I know a lot of it was focused to DO applicants, because there are some special considerations for DO applicants versus MD applicants in all fields, but also at PM&R. So I think a lot of this stuff, the skills that we might develop in osteopathic schools, my other MD colleagues in my residency, definitely develop over time. But I can speak for myself that there's just a larger emphasis on the musculoskeletal system, and which is kind of like obvious when you think about osteopathic manipulative medicine. But even going one step further, I've noticed learning things like viscerosomatics and then getting to your spinal cord injury rotations, you can kind of put together like the sympathetic changes that happen in a spinal cord injury much quicker, and you don't really have to think about, if it's at this level, is it going to affect the heart? Is it going to affect, this somatic function, et cetera? So I think kind of understanding the body and how everything's integrated is a nice approach that we get in osteopathic school.
Great answers. Anyone else?
Yeah, I agree with everything that's been said thus far. And I think the only thing I'd also add is having that kind of additional lens that we can help view patients' problems through, and just that kind of open-minded, integrative approach. So many patients we see in clinic especially have already been to several providers, and oftentimes, chronic pain issues that don't respond to kind of traditional biomedicine. OMT can be great for, and then also, acupuncture, aromatherapy, all the things that we kind of get tuned into in PM&R. I think as VOs, we're teed up well for that. So.
Excellent.
Yeah, I agree with, what everybody said. I know for us here at UK, we also have one full-time OMM faculty member and one that does 2 days a week in clinic of all OMM for our patients, and we get a large referral base. So definitely useful in residency.
Well, fantastic. In addition to building trust and enhancing your familiarity with the anatomy, it seems like a lot of patients really take well to the osteopathic approach. How would you say your programs view OMM?
So I'll speak for my program. So I think everyone's very open to having DOs and having people perform manipulation. It's one of those things where I think with a lot of clinical interest, you have to kind of pursue. If you want to use something, like, you're going to be able to utilize it. If you want to use the ultrasound machine on an inpatient rotation, you're going to grab that ultrasound machine and use it. I think the same thing goes with OMT. I do have a few of my attendings who are osteopathic physicians and do perform OMT. I feel like it's much more selective. We don't have, at least within our program, we don't have like a dedicated rotation or a clinic or anything like that. But I know for me, if it's something that I want to continue using, I have to pursue it. And I think there's always opportunities. I think just like any other skill, you get better the more you use it.
I came down. Go ahead.
Go ahead. Are you sure?
All right, I'll go.
All right.
My program was pretty. I think Texas is kind of barren, at least in Houston, in regards to people who use OMT. I know Dallas has DCOM, which they're very good there. But Baylor, it seemed like not really many people had OMT experience. So I had the chance to kind of like bend the arc and change people's minds down here. And that's a little bit different than Northeast, I believe. I think that Philly, that region, is a little more used to seeing people who use OMT. But I think slowly, me and some of my colleagues, my one co-resident was also an OMM fellow before. So we helped change, kind of like bend the arc of people's thoughts at Texas Institute of Rehabilitation down here. So.
We have a visitor. Great answer. Do we have anyone else? Shall we move on to the next question?
Sorry, my cat wanted to say hi too. I was just also going to add, I think in Charlotte, there's maybe midway between the Northeast and Texas, not just geographically, but also with osteopathy. So there's some providers at our program, we don't have a set up curriculum for it, but definitely everyone's kind of interested and wants to, learn more about it from the MD side of things. And then as DOs, we're supported in kind of pursuing that. But like Dr. Smith was saying, kind of more so requires a little bit of effort on your part, but definitely that effort is supported if you're interested in it. So.
Wonderful, good to hear. Any others?
Yeah, kind of like they're all saying, it's kind of something typically I feel like in residency, it's something you're going to have to pursue if you want to do it and keep doing it. Our attendings at UK are very open to it. If you want to try it and they think it can help your patient, that's great. We do have about 50-50 DO and MD faculty. And some of our DO faculty actually put in on like non-COVID times. We'll spend like a day or a night a week and teach some of our MD residents some osteopathy if they would like to learn as well.
Well, perfect. Thank you all for sharing. just as a general preview, momentarily we're going to be asking some questions about the journey to PM&R, in addition to questions relevant to the application cycle. But we want to ask a few more questions that are DO specific. So speaking of OMM, if you wouldn't mind sharing how you are using, or if there are any particular techniques that you feel would be good for students to stay fresh and brushed up on, and also maybe mention again what discipline you're applying them to. Thank you. And I'll maybe, so just to facilitate a little bit quicker, I'll call on someone and then we can bounce off there. So Dat, would you mind sharing first?
Yeah, OMM skills to brush up on. Our tier was one of the model systems, one of the model systems for brain injury. So I wasn't that good at cranial, but I got to use cranial on a lot of my patients and in front of my attendings with some pretty interesting reactions in regards to the autonomic system for sure. So if you're interested in cranial is awesome. And just like simple myofascial release, especially when in chronic pain, there's a lot of CRPS patients, and we can't mash on them like we like with HBLA or something. So all the bread and butter stuff that you learn in DO school carries over very well. So there's not really, if you have a technique that you're good at, then just keep honing it in residency.
Excellent. Anyone else?
Yeah, two things that come to mind. Suboccipital release, it's good for everyone. It's good for your co-residents. It's good for your post-concussive syndrome patients. Really can't hurt anything with it. And the other thing that I would say is with your low back pain, or really any pain patients, fixing their sacrum and pelvis will do them wonders.
Fantastic.
Something I've had awesome success with is facilitated positional release for piriformis syndrome too. So if you ever have a patient with kind of some sciatica going on, I think that's a great one to try. And again, low harm and could have good benefit. So.
Well, excellent. I hope we're all writing these down. One more question that is DO specific. In regard to the COMLEX, as everyone here knows, osteopathic students are required to take the COMLEX, but many students also elect to take the USMLE Step 1 and Step 2. Did you all take Step 1 and Step 2?
This is the question of the century. To take step or not to take step. I personally didn't take any step exams, and I interviewed fairly well. I matched fairly well, but part of me is regrets maybe not taking the step exam, because there might have been some places that I was interested that I didn't get invitations to. But who knows, right?
I took both COMLEX and the STEP exams. I interviewed well. I matched at my top choice. I don't know if that really gave me an advantage. I'm also not sure how it will play out, because if I'm correct, I think STEP is going to pass fail. So I don't know if there's still going to be a numeric score that's being reported or not. So it definitely, things this year are different in regards to interviews. A lot of them might be virtual, but finances are another thing to keep into consideration. The testing isn't cheap. The interviews can definitely rack up, and I don't know how much benefit it added. That being said, I did take both, and I wouldn't change my path. So kind of whatever works best for you.
Mm-hmm.
With Step 1, I did really bad on it. And I think it knocked me out of a few interviews, but I landed in the place that I belong. So I'm very happy. And looking back on my experience, I wish I didn't take it. But that being said, fellowships did ask me for my USMLE score.
I did not take either step exam, just did the COMLEX. Like Michael said, there's definitely some programs that want step. So kind of got to see what those programs are. And if it's a program you're interested in, you may want to take it. I interviewed well. I got the interviews I wanted. I went to my number one choice, so it didn't hurt me. But like I said, there's definitely some programs that want it. So you just kind of got to try to figure out if the program you want to go to is one of those.
More or less same story for me. I only did COMLEX. I think, maybe there were a couple interviews that maybe that factored into me not getting, but I got interviews at most of the places I wanted and felt happy with kind of the amount and location of them. Ended up matching at my number one as well. So I don't think it necessarily impacted, the trajectory, but a consideration to kind of take in depending where you're looking at.
Fantastic. Those are great answers and valuable to know. Yeah, because as you said, Dr. Smith, that is the main question that so many are asking. Want to ask you, for those of you, this question is going to be directed perhaps more toward preclinical students, but for those of you who knew that you wanted to go into PM&R early on, what type of activities were you involved in to show your commitment to the field?
I think when I kind of first found out about the field of PM&R, just joining with the student interest group, and then when I had some spare time shadowing a physiatrist just to get a better idea of, what the field entailed. And that was, for my own sake, just to make sure, is this really what I think it is and what I'm interested in? And then also I think that reflects well when you do end up interviewing, just showing that you've had some exposure, which also you can get during clinicals too, but those kinds of things. And then I think just like most things, continuing to do whatever it is you're passionate about, and that usually will feed into your career in one way or another.
Yeah, second that. I joined the PM&R interest group, and definitely I think that helped. I did some shadowing for like game coverage for basketball and lacrosse games with a physiatrist in town. And then I went to the conferences, like the AOCPMR mid-year meetings. I started going my second year, I guess, so kind of preclinical. But that was kind of things that showed my interest, I think.
Go ahead, Dad.
Oh, sure. I was a kinesiology major in college. So I didn't find out when I found out about PM&R, I was like, oh my gosh. So if any of you guys have an undergraduate degree in kinesiology, know for a fact, and definitely emphasize that point in your interviews, because it'll play a big role, as it did in all of my interviews, all the way from medical school, residency, and fellowship.
Dr. Clark?
And what I was going to say is, I think I kind of echo what Kirstin said. I decided towards the end of my third year that I want to go into PM&R, and I did as many away rotations as possible. And I know that might not be an option this year, but as much exposure to the field that you can get. Because, I've run into colleagues now who are, second, third year internal medicine residents, and they still don't know what PM&R is or what we do. So if you're going to an interview and you really haven't spent any time with the physiatrist and all the different sort of facets that our specialty has, I think that would be a disadvantage. So just really any opportunity you can to shadow or do a PM&R rotation will serve you well on the interview trail.
Fantastic. These are excellent answers, and I think we want to move a bit more quickly through the questions. So I want to jump to the next one, if that's all right. Was there anyone who was actually interested in another specialty and then decided on PM&R? And if so, what made you choose physical medicine rehabilitation?
I wanted to do orthopedic surgery, but decided I wanted some other lifestyle factors that weren't in line with being a surgeon. So found PM&R and specifically sports medicine that still has a lot of procedures, but definitely not quite the hours or the years of training as a surgical specialty.
Not a direct answer to that question, because I think I knew I wanted to do PM&R pretty much the whole time, but one thing Stephanie said that made me think, just keep in mind if you are doing AWAYS or have done AWAYS, just know that PM&R is such a wide field. So you could do a rotation somewhere and be like, oh, this isn't for me. But then you could do one somewhere else and be like, oh, this was amazing. Whether it's inpatient, outpatient, everything in between. So just keep that in mind too.
A great answer. Anyone else want to comment?
Quick comment. So I actually want to do family medicine coming in, and that changed for a few different reasons. But one thing that I do like about PM&R that you still have this mentality of, depending where you work, you can still have very much this primary care mentality just with a certain patient population, which I like. And then also if you go inpatient rehab, it's a big hospitalist kind of component to it also. So if you like the inpatient hospital setting, for people who haven't been exposed to an inpatient rehab unit, it's very similar, except you get your patients a lot longer. You get a patients for 2 to 3 weeks instead of 2 to 3 days.
Wow. I imagine that, some of your stories, a lot of the listeners can resonate with, because I hear similar stories often. Anyone else? No? Okay, so last question for that I'll ask, or I think I might have 2 more. For anyone who might have a red flag on their application due to leave of absence, a bad board score, or any other reason, how much do you feel that impacts someone's ability to match into PM&R?
I don't know if I have a direct experience with that question, but I know from the people I've talked to, and I can speak for my program, is we look at more than just the board score. We had a residence, like a virtual kind of town hall meeting for our program recently, and our program director was kind of spot on. These are things we're looking for. And the things that I see in my co-residents and I see in myself is, it's a compassionate person. It's a person that works well with the team. It's a person who is passionate about the field. And high board scores a lot of times will get you in the door, but not necessarily keep you there, if that makes sense either, especially in PM&R, I feel.
Yeah, and going along with that, I think a lot of people lose sight during interview season in general. If a program offers you an interview, they're interested and they've seen all of your records, so you don't need to walk in with any fear or trepidation about any kind of bad mark. Be honest and open about it, but don't kind of let that consume your interview process or your thought. Because again, if they invited you there, they saw something, so show them why you're great, why you should, why they should want you at their program.
Very good.
Yeah, I agree with what both of them said. PM&R as a specialty as a whole, I feel like it's a lot about the person, and who you're getting. You got to be compassionate. You got to fit well with the team. And then you have those red flags, and they've invited you for an interview. They obviously know that. Just be forward about it. Be open. Like Michael said, I don't have direct experience, but I think, that's kind of what I've heard from my uppers and attendings.
Excellent. Last question that I have, and then I'll pass things over to Grant, is for those who maybe are still wondering about the field of PM&R, what would you say is the most rewarding aspect for you? And what would you say is perhaps the most difficult part of being involved in the field?
So I think the most rewarding part is you see people get better. You see that patient who had a massive intracranial bleed start talking again. You see the person walking for the first time. see people who you didn't think were going to go home end up going home. I think it's so rewarding, and you miss that a lot in medicine. You only see like the kind of that snapshot of where there's like that big tragedy. So we get to see that. And I think also on that side, the hard part of the field is a lot of the social stuff that comes along with that. People don't have the support. People, don't have. I mean, we have problems in the medical system in this country, and I think we really get to see it in our field. We get to see the disparities in our healthcare, which is unfortunate.
Yeah, indeed. It's powerful. I can remember a time, the very first time I was exposed to someone with locked-in syndrome, and then a few weeks later, where before they could only blink, they were all of a sudden talking and moving and saying thank you and communicating verbally. It blew my mind. Anyone else have a comment on that question?
I'm just going to echo what everyone else said. The most rewarding thing in PM&R is the perspective you get from your patients and how, you can apply that to your own life and the world around you and just become a better person from that.
Kirstin, did you have something?
Yeah, more or less kind of what everyone's been saying too. But I think obviously I'm biased being in rehab, but it's such a rewarding field, getting to see people make the strides of functional improvement that they do. And I think the flip side of that is, we see people at their most vulnerable, which is a really, amazing place to be able to help people. But also as I think most people in medicine are empathic, you can go through some heavy stuff with your patients. So just kind of knowing that going into your spinal cord injury rotation, and just really doing your best to be present with patients and also, hold that space for them, but also, process things on your own too.
That's powerful. And last chance, any more comments before we move on? Well, wonderful, excellent. At this time, I'm going to transfer things over to Grant Albritton. He's our vice president, and he's going to talk about ask some questions in regard to the application and the interview. Thanks very much. Grant, take it away.
Yeah, thanks, Edward. Appreciate it. So yeah, we'll just keep chugging along here. This will kind of be the meat of our talk, talking about the application cycle and the interviews and your guys' experience and some advice that you guys have for us. So first question, we'll lead off with, what is one single word that you feel describes a strong PM&R candidate, and why that word? Dr. Smith, we'll start with you.
Thanks for picking on me. Strong PM&R candidate. I really think compassion is the word that first comes to mind. So much of what we do is like based on that. Just like the things we talked about, why is PM&R so special? It's for those things, and you need the candidate that is able to be compassionate to the difficult situation, because it's hard. It really is, and it's such a team effort that you got to be a team player. You got to be compassionate with the other specialties and the nurses and the physical therapists. And I don't think people realize. I didn't realize it, like how many players are in the game until I really started getting in my inpatient rehab rotations. It literally is a village of people, like getting these people better.
Yeah, I can go next. To make it one word, I'll choose collaborative. It really is a team effort. As Michael was saying, we rely so heavily on our physical therapists, occupational therapists, and speech therapists. You might be there as the doctor kind of overseeing or facilitating things, but you do nothing alone in this specialty. So someone who's collaborative and works well with a team player.
Yeah, team player was going to be mine. No matter what part of PM&R, if you're inpatient, if you're, spinal cord, brain, if you're sports, if you're interventional pain, you're working closely with, PT, OT, speech, athletic training. Somebody else is going to help you take care of your patient and get them where you want them to be. So you really just have to work well and, ask for help if you need it.
I'm gonna still compassion too. If I held interviews at Baylor, and if there was a sense that I knew the candidate across from me was able to put themselves in someone else's shoes without kind of getting too deep into it and not being well themselves, but putting themselves into someone else's shoes and just realizing, you know, this patient just had a major crisis in their life, and you know, you're thinking about what their housing situation is like and if they have family support. So yeah, compassion for sure.
And if I had to add a new one, I'd go with dedication. But I think that works in the same way. I think in order to have that level of compassion, to kind of go the extra mile for your patient, to take the time to make things work as a team, to figure out that complicated patient that, you know, was referred to you to try and get a diagnosis or treatment plan going. I think that takes some dedication. So.
All great answers. Thank you all. Next question here. With limited opportunities for auditions, what advice do you have for standing out during this virtual application cycle? Dat, we'll start with you.
That's really tough. Everyone has to come to the reality that programs are going to want to take more of their internal candidates. So that's just a fact across the board for all fellowships and all programs right now. You just have to realize that. For the programs that you want to make yourself stand out, I mean, anything with, I would say, I would go back to this whole thing, OMM, you know, like the fact that I did the fellowship, or the fact that you're a part of SAAO or AAO stands out to certain people who are interviewing you across the nation.
Yeah, I think one thing you can do is, if you know you're looking through programs and you see that different programs are doing either virtual happy hours, or I know us at UK, we do our Wildcat Wednesdays every other Wednesday. If you tune into those kind of things, I think the people on those notice and, you know, can recognize your name or face. Two would be, I know at least at UK, all our residents are super open. If our emails are on our website, if you want to reach out and have questions or just show interest, you know, it may take us a second to get back to you, a day or two, but somebody will answer you. And, you know, we'll kind of note that. And I think program coordinators are a lot the same way. And we talk a lot with our program coordinator. I think that's kind of the big things, is just, you know, if you see things like that, you know, at least try to at least make an appearance, show that you're interested.
Yeah, I'll piggyback on what everyone else is saying. I feel like programs you're interested in, like, really figure out a way to be memorable. You know, however that looks like, you know, it's going to be unique for everybody. You know, and I think there's a fine line. Like, you don't want to be weird and like extra, but you want to, like, you know, be interested and rememberable. So that looks different for everyone. You kind of got to feel the crowd, but, like, you know, Kirstin with her pup or her kitten, like, you know, that's something that's memorable, right? You know, put a picture of you and your pet, you know, if you feel the vibes is right, you know, that's how I think. And I do agree with what Mike was saying too, is it's more than just the program coordinator or the program director. Like, everyone has an input, and, you know, like, one email to the program director can go a long way. And then lastly, what I would say, and this is what I see a lot of people do, and I did this too, is, you know, I would send out emails and they were just very generic, and you have to, like, put something in there that, like, gets their eyes. You know, I'm interested in your program. This is why. I heard about this. This aligns with my clinical interest. Like, whatever it may be, it's going to be like one little extra step that is going to get you kind of, like, one step above to being re-recognized.
Yeah, and echoing off that, sending emails, I think thank you emails or handwritten notes, if you have pretty penmanship, which I do not, but just continuing to show your interest in a particular program throughout the interview cycle would never hurt you.
Awesome. All great answers. Kind of to go along with that, what are your top 2 important factors that you personally considered when ranking your programs come match time?
I rotated at Carolinas, and that was a big factor in me picking it as my #1 choice. But the thing that sold me on it was, in addition to kind of all, the stuff on paper, having a good experience in this, a good experience in that, really was the culture of the program. So I'm so sad that you guys aren't going to be able to do your away rotations. But like Stephanie and Mike were saying, reach out to people that the programs you're interested in and really get a feel for the culture kind of through them. I know we're all going to be open to talking more than usual probably during interview season, just because we know you guys aren't able to get that really in-person experience that you would otherwise. But I definitely think culture and just making sure in a place that you're going to be happy for 3 to 4 years, and making sure it seems like a good fit, which I think is going to be the real challenge of interview season without in-person interviews.
Yeah, for me, #1 was fit with the residency and the attendings. Again, tougher this year with virtual everything. I think #2 was kind of just a broad PM&R learning environment. So I wanted good inpatient and good outpatient exposure to make sure I was prepared to see anything by the time I left residency if I wanted to do a fellowship or not. And I think that was the 2 big things. And then to cheat, #3 is find a city you can live for 4 years, because you're going to be there for 4 years.
My kind of top 3 things were very similar. It's kind of culture of the program, and then even though I had specific clinical interests, this is the time to really learn rehab, and I wanted to be able to leave residency and be able to do anything, and at least in the general respect to PM&R. So that was important to me. And lastly, this didn't really apply to me. I'm single. I got some family back in Florida, but I really would emphasize that family consideration, if you have kids or significant other, you have to bring all that into the equation, because like other people said, you're going to be there for either 3 to 4 years. And I think it's important, the location you're at, if that is something that you have to consider with however your dynamic is.
I kind of have the same #1 as everyone else. It was really the fit of the program and the culture of the people who I would be working with and spending a lot of time with. And then going in with special clinical interests, specifically being sports medicine, I also was more interested in programs who I felt would sort of set me up to be a competitive applicant for fellowship. So that was also something that was really important to me when I was picking programs.
I think it should be important if you are thinking ahead, like Stephanie said, to fellowships, research the program and see if they have their own internal fellowship or good mentors who've written books or are kind of like heavy hitter names in the field, because they can give you access to the networking that you need to get to where you need to go. Baylor was definitely one of those sites for me, even though there's no internal pain or sports fellowship. There were people who just shot me all over the nation.
Awesome. Thank you guys for giving your top 2 and 3. Appreciate that. Kind of going along with that, how many programs did you personally apply for during this process? Did you feel like it was too much, too little, and kind of that advice going into this year where it's more virtual? We'll start. Yeah, Dr. Clark, go ahead.
Oh, I can start. I guess I maybe had a little bit of a fear tactic going in to applying to residency, and looking back, I applied I think way too broadly, because I ended up applying to some places where mainly based on location, I knew I probably would never want to go because I had no connection there. Granted, I had no connections to Rochester, Minnesota, but I had the opportunity to rotate here and meet the people, and that was really the deal breaker for me. But if there's a program that if you're either concerned about matching, you know, and so you think you're going to apply really broad, but if there's a program, you know, for some reason, be it location or you've just heard things that you would not want to go to, then don't apply. It's not worth it. And, you know, there might be someone else who wants that spot, and it can become then really stressful when you have to cancel interviews and might end up adding more stress in the end. So I think, you know, apply to a decent amount, but don't overdo it.
I think I want to say I applied to 30 PM&R programs, and it adds up. It's a lot of money, and then you have to factor in all your internship programs in there. So I would say I was probably in a good number with 30. It's really a balance. You have to kind of, I guess, gauge your competitiveness also. I think what's been 4 years now, PM&R has come completely filled. So it's popular now. You know, the secret's out, and I think it's one of those things that when I talked to residents about it and I got their advice, mostly what I got was, this is the time to be more conservative than less conservative. So I think if you're concerned, I would probably apply more. But what Stephanie said, if you are absolutely like, I am not going to go here for whatever reason, don't waste your time. You know, it's just more money down the toilet.
And can I add one more thing? I did not do this, but if anyone who's listening is planning on couples matching, I would strongly recommend you working with whatever kind of counselor, whoever at your school, to help you through that process, because the match by yourself is challenging, and trying to throw another person in that mix and aligning programs can just get to be a lot. So make sure you're using the resources that your school has available to help you through this.
Yeah, just kind of ditto what they said. I think I applied to 25 programs, got the number of interviews I wanted, ended up having to cancel one late, which I felt kind of bad about. So, but this year's a different year. Gauge your competitiveness, and like Michael said, I think this is the time to be a little more conservative with, you know, the year we're having and everything being virtual, and, you know, you're not spending the money on plane tickets and travel. So you can take that into account, but don't apply anywhere you don't want to be. That's just a waste of everyone's time.
Awesome. We'll roll right on to the next question here. So let's talk about letters of interest. Did you guys send any out? If so, to how many programs? And do you remember when was a good time to send out these letters of interest? Dr. Parrott, we'll start with you.
Yeah, so I did send a few to programs that I felt I fit in well with and was really wanting to either A, get interviews, or B, rotations. So I know one program, like I didn't get a rotation off the bat, so I sent a letter to a resident as well as their program coordinator about why I was interested in the program. Ended up getting the rotation later. And then just after interviews, I know Stephanie mentioned this, but I wrote handwritten thank you notes kind of the day of the interview or day after, so the interview was fresh in my mind. I could talk up to each attending about, you know, what, or resident, what was talked about, thank them for, you know, kind of an individual type letter, just to show that I really cared and paid attention.
I wrote 3 kind of love letters, as it is called, to my 3 top programs. And handwritten thank you notes, I did it when I could. There was a few of them where I sent emails, and I think anyone that you came in contact with that had a meaningful experience with, writing them a thank you note or an email definitely goes far. Program coordinators, other residents, more than just the person that interviewed you.
Awesome. All great answers. We take that advice with a lot of weight. We appreciate that. Next question. I'll start with Dr. Weider. What role, if any, did research, whether it be publications, abstracts, what role did that play in your interview process?
So I kind of dabbled in research in undergrad and then in med school. So I think it was good to have some background there, and then mostly just had like maybe a handful of posters at some of the conferences throughout the years. So not like I had any longitudinal impressive research, but I think just showing that I had some interest in the field and presenting interesting cases at those meetings definitely came up at nearly every interview, I felt like. So yeah, I think it was helpful to have some exposure and to show that I had some interest in doing more research, or yeah, but I think definitely it's something that can kind of set you apart, but not necessarily a deal breaker if you don't have like some amazing rehab related research project you've been working on over the years. So.
I had a handful of case studies. There was one OMT related project that never really went anywhere, but we got IRB approval through my university. So having IRB experience, I guess, was nice. There's going to be people out there that interview, and they're the researchers. They're parts that want to make it part of their careers. And I think this goes back to like, if you don't enjoy whatever you're doing, like I don't think it's gonna be worthwhile. If it's just another box to check in your head, I don't think it's worthwhile. I really don't. I think people are gonna be attracted to and gravitate to the things that you're passionate about. People are gonna they're gonna remember you for that. So I wouldn't stress it. I think having a few case studies is nice. I think it's also good. As me being someone who doesn't want to do research, have no interest in it at all, understanding the research process in any field you go to, I think is important, and being able to kind of digest and break down primary literature is important. And I do it very poorly, but I think it's a skill set that as a good physician that you need.
Yeah, I didn't really have much research in med school. I did one case presentation, and it actually happened after interviews, so nothing to talk about. I will say, if you have research or case presentations and you put that on your CV, know it backwards and forwards, because they're going to ask about it in the interview if it's on your CV, and they want to know that you learned from that research and you didn't just throw something together and call it a case presentation just to have on your CV.
And just to kind of piggyback off this topic, because I know people aren't going to have the same amount of exposure as fourth-year students and getting rehab specific rotations, but you can probably find rehab topics in almost any field you go to. You really can if you look for them. My last rotation as a medical student was kind of like my medicine sub-I, and we had someone that came in with a pain pump and like unusual presentation. I wrote that up, and that's been accepted to conferences too. So you can find this stuff even outside of the dedicated PM&R rotations.
I guess I'm kind of the old dog of the group, so I feel like I slipped in before kind of like the research wave came out. It's going to be a fact that every program is going to want you to do a quality improvement project. So any type of exposure to research does look good on an applicant's CV when they're coming in for an interview. But like Dr. Parrott said, know it in and out if you did something. We don't want to see that you just put half effort into something and just put on the paper. And after getting familiarized with research in residency, I can tell you guys that sitting across from someone who's put the time in and done a substantial amount of research, I have the utmost respect for them if they got a research project done as a medical student.
Awesome. Thank you all. We take that advice again with a lot of weight. We really appreciate it. Next question here. What is one tough, difficult, or thought-provoking question that you remember from your interview trail? Dat, we'll start with you.
My interview trail, like, it was just all discussions. Like, it was just most of the places were just really chill. They just wanted to get to know who I was. Places like there were two programs who did kind of pimp me, which was kind of, I guess that was the hard one. They like asked me to pick like spinal cord injury, brain injury, or stroke, and then they gave me like they just tried to make me go through a case and see what my thinking process was. So I guess those were the only tough cases. But other than that, most of the interview should be pretty chill, and they just want to get to know who you are, what your hobbies are, what your life is like, and how you can relate, what you've done in your life to relate to the patients that you're going to see.
I'll say one question that you'll probably get sick of hearing is, what questions do you have for me? You're going to get it from every single program. And if, so come up with a list of things. Something I think that really helped me was, you asked a question earlier, but there were 3 specific things that I wanted or was looking for, evaluating every program for. So if you come to a program knowing what you want and then asking the program kind of how they fit into what you're looking for, as opposed to the alternative. Again, they offered you the interview, so they want you there. But if you just have thoughtful questions for when you get the what questions do you have for me, as opposed to just kind of sitting there with a blank stare on your face. Even if you ask the same question to every single program, it's fine. Just have something thought out ahead to ask.
Excellent. Next question.
One more thing.
Yeah, go right ahead.
I think there's a book called Isaac's Guide to Get into Residency. There's an excerpt in that book that goes through exactly what Dr. Clark said. What questions can you ask the program? So I would try to find like just an online list of something like that and just go through your head beforehand.
Nice, great advice. Thank you. Next question. Again, kind of dealing with, again, good transition here with the resources. What's one resource, if you had to pick one, even though there's plenty of amazing ones, what's one resource that you feel all PM&R students should have going into this cycle?
Man, I would say that Isaac's book, or I think there's a book called 200 Tips to Get into a Residency. I wish I had that when I was in MS1, because it brings you through like, okay, writing a personal statement. Should I send these letters to the program directors? Of course, it's gonna be different now in COVID times, but it brings you through like personal statement. What should you write about? Should you make it interesting? Like blah 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 blah. So it's a little mechanical, but that's just how I worked. And once I got the foundation down, I could put my own flavor on it.
I don't know if this is exactly a resource for what you're looking for, but I think one thing that helped me, because I didn't do any of that kind of stuff, was I had a mentor that had recently went through the process, or know someone that recently went through the process, or even if it's just one of us and you don't know us that well, but you can reach out to ask the questions and, just be prepared as you can for kind of the interviews and what kind of things they may ask and what kind of things you may want to ask, or what you should be looking for possibly in programs. I think, just having someone that's done it recently or semi-recently is a huge asset.
Excellent. We have a question from the chat that kind of applies to what we're talking about here. Any advice on applying for transitional years? So if anyone wants to speak on that, go right ahead.
Yeah, I have a few pieces of advice. So not necessarily, let's just talk about intern years. So it's transitional years, and usually prelim medicine. There are surgical, and you can even do like, I think, an OB like intern year. I don't think most PM&R docs do though. One thing that I didn't do that I didn't know was a thing is if you're applying to prelim medicine intern years, a lot of times they want like a letter of recommendation from like a program chair in internal medicine. So it's something I didn't have, and I think I applied to a lot of medicine programs I didn't get interviews in. I think that's that caused some of that failure. The other thing that I would say is for transitional years, prelim medicine, whatever, find one where you're still going to have like a really strong basis in medicine, because you are going to need it. When you're a second year resident, you're by yourself with your attending there rounding with you, and essentially you have to manage things. And, you know, depending where you work, you may or may not have like that support from consultants and, you know, medicine team and code teams and all that fun stuff too. So more so than, let's say, radiology, you know, because you'll be working with them who, you know, they're essentially doing radiology. We're still doing a lot of medicine. Oh, and one last thing. If you get a PM&R rotation in a city that you applied to, like whatever prelim program, send them an email being like, hey, I got it. I'm interviewing at, you know, this program. It's in your city. This is a place I'm interested in. I think I got like 3 or 4 extra intern year rotations by just doing that I wouldn't have gotten previously.
In my opinion or experience, I did a TY year. I didn't do an internal medicine prelim year. It doesn't matter, or at least it didn't matter too much for me. I think the most important thing was, you know, just to get one. And in some aspects, I found that that was actually the harder part of the interview trail. I felt like I had a ton of PM&R interviews, but it was more those prelim and the TY programs. But even though I did a TY program, I didn't do internal medicine, I felt adequately prepared to manage things as a PGY too. So it really doesn't matter. Your programs aren't going to think one way or the other, whether or not you do one. So just match into one is fine.
Yeah, and just to piggyback off of that, I also did a TY year. Felt like I got really good training, but I would caveat that with make sure you make the most of your internal medicine experience. Just the way things are going in rehab, the acuity of inpatient rehab is getting higher and higher. So especially during COVID times, I don't know how other hospitals are impacted, but I think that's a consideration to take in too, as we kind of are most likely going to be offloading some more acute care. So just try and get a really solid foundation, which I think is good advice for anything. Make the most of your time there, but especially for those internal medicine months.
Great, thank you all. We got a few more questions from the chat here. Next one, what are some non-PM&R electives that you would recommend to rising 4th-year medical students or 3rd years to take after auditions to best prepare for intern year and the upcoming PM&R residency?
Neurology.
Rheumatology.
I didn't do this, but I saw it online the other day. I thought it was a good idea. Palliative care. You have a lot of tough discussions with, you know, PM&R patients, and, you know, the compassion and the empathy you get for patients on a palliative care rotation can go a long way in those discussions too.
As an intern, I did a wound care rotation, and I by far think it was one of the most worthwhile rotations in my entire medical experience.
I would just add sports medicine, and then I also got to do a urology rotation as a 4th year, and got to work with a neurogenic bladder specialist. So keep that in the back of your mind. I feel like that's not one that we really think about often, but actually is really beneficial in rehab.
Excellent. We actually had another question pop up. It's kind of specific here, but I'll go ahead and ask it. It said, I enjoyed both PM&R and pediatrics, but have not gotten to experience peds PM&R. This came from a medical student. Can anyone attest to what that experience is like with your pediatrics in PM&R?
At least at Texas Children's, you're going to see bulk patient majority is cerebral palsy patients. If you go to any of the bigger centers like UPMC or kind of the main universities in big cities, you're going to see a lot more of the zebras, like the SMAs, what is that, and all of those diseases where molecules are missing, where we had to like memorize for the boards. But bulk CP, bulk spasticity management, and you gotta know your DMEs and making sure that these kids are set up for schooling and all that kind of jazz.
I don't have a whole lot of experience in pediatric rehab, so I can't, speak to like the nitty gritty. But for those who are interested who don't know, it's the only PM&R specialty it's if you do fellowship, it's 2 years. And I don't know exactly how the boarding goes after that, but essentially there's, essentially you're a pediatrician and a rehab doctor. So, and then you're a PM&R doc. So I think there's multiple boards exam you have to take. It's one of those things I think you really have to be passionate for. I think it's probably comparable from like a financial standpoint as most other pediatric specialties, which, overall is lower than adults from my understanding. Here at UPMC, I had a little bit exposure. We have a children's hospital, and you do see a lot of like these really just kind of strange, like inborn metabolite errors. And there is like I think even more of like this big psychosocial component, because you're essentially seeing the person through school, make sure they have the resources, making sure the school's compliant with the different, laws that people with disabilities and students with disabilities need. So it's big, but I think it's really worthwhile. I think something else that's really interesting, which is growing in PM&R, is this transition from the pediatric rehab patient who has CP or spina bifida, et cetera, into the adult world, which is I feel like it's growing.
Of note, the Peace Fellowship did not fully match this year, so my friend actually walked into Seattle onto their PEDS fellowship. So it's kind of like at a lull right now, and pain's kind of probably at a high currently. Pain in sports for sure.
Yeah, we do the majority of our PEDS here at UK in our third year, and I just haven't gotten to do it. The bulk of that, like that said, is we get a lot of CP, a lot of spina bifida stuff, spasticity. We do work with our pediatric orthopedic surgeons and do some like scoliosis management and things like that as well. And then we, just on our individual brain spinal cord units, you're going to have your occasional kids that come through as well, where you get that experience. But the bulk of ours is spasticity, CP management, things like that.
And then there also are combo programs. So you want to do a fellowship, you match into, your PM&R / pediatric PM&R residency. And I don't know much about them. I know there's a handful of them out there, but definitely go online and check them out if you're interested.
Awesome. Thank you all for your answers. Got a question in the chat here. It's kind of general and a little personal. So we'll start with Dr. Clark here, but as individuals, what have you learned in order to get through the challenging times in your career? So what have you learned to get through those challenging times?
What have I learned on, or what have I leaned on?
Oh, it is leaned on. Excuse me. Yeah, okay. Sorry. What have you leaned on? Go ahead.
For me, it's been my family. I have an older brother and sister, and I'm really, really close with my parents, my aunts and uncles and cousins. So, I talk to all of them multiple times a day. That, they've been my rock even through medical school and now. And then also other things that I'm passionate about are nutrition and exercise. So definitely find healthy ways to let stress out. For me, it's exercise, be it running, cycling, cooking a meal, getting together with friends. I know that's more challenging now, but those are really what keep me going. And then kind of going back to, hardships are going to happen. Things are going to happen throughout residency. had a family emergency during my TY year, and it was really the people who came and supported. They stepped in, they covered for me. You definitely want to be at a program that's supportive. So leaning on colleagues also during a time of need has been instrumental for me.
Yeah, ditto. I lean on predominantly my family, but also we've got a very close-knit group of residents and attendings here. And, you know, just reaching out to them if you need help. You know, we've sent residents home, like other residents have sent residents home and say, we got your work today. Go do what you need to do. Our program director is super open. Her door's always open. So I know a lot of residents kind of go in there and kind of hash things out with her as well. So I think it's just the supportive cast of colleagues is huge.
I echo that for sure. Just the colleagues around you, but the number one skill that I fell upon these past 10 years that has helped me the most, and I would say the one big thing is a meditation practice, for sure. I'll just leave it at that. You explore for yourself. There's a bunch of apps out there, but I would say the one thing I've leaned on time and time again is just breathing when times get hard, and just kind of self-reflection after hard days, even after good days. So it's really helped me. So I really hope that some of you guys get harness that power.
I agree with everyone's responses there. I think kind of bouncing off of that there, a morning routine has been a big thing for me. So I think throughout med school, residency, pretty much every stage of the process, your schedule's constantly changing, your requirements are constantly changing, a lot of change all around. So trying to build some sort of routine that kind of sets you up for a good way to approach your day, whether it's meditation, whether it's, you know, just having your cup of coffee and peace at home in your morning before you leave your house, whatever works for you, just finding something that can kind of be your dependable way to start your day on a good stride.
Excellent. Well, thank you all. It's pretty much all the questions that we had. And with that, I would like to turn it over to our president, Andrew Deng, to kind of close us out and some final remarks.
Perfect. Yeah, I guess, you know, we're kind of out of time tonight, but I want to thank you all so much due to just the overwhelming amount of support and participation and questions that we received for the panel. We're hoping to host a second resident panel sometime in the future. So if we weren't able to get to all your users submitted questions tonight, we'll try our best to get to them. But if you guys do still have any questions at the end of this panel that you want answered, feel free to just kind of stick around. I just want to make sure that, you know, we get done at a reasonable time. But yeah, thank you guys so much. This was incredibly, incredibly helpful. I think a lot of these words are things that we can take on auditions and our interviews and everything like that. So, you know, as always, if you guys have any other questions, you can stick around in the chat. I'm sure, you know, some of us will kind of hang around for a little longer. But if not, thanks for coming, everyone.
Thank you
For having us.